This episode is sponsored by PAX, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PAX. Every bag is handcrafted by expert tailors who understand the demands of postpartum care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PAX absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PAX bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PAX doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PAX are built to perform, made to last. Learn more at pax.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're going to look at a maternity compilation. So we're really going to focus on the fundamentals of good both maternal care but also neonatal care as the newborn is delivered. So we're going to start off with Camella Main. Camella is a consultant midwife with over 14 years now of experience in the field. And we really discuss in this episode thermal care and the importance of thermal care. We also look at recognizing key signs and symptoms indicating active labor and imminent birth and effective maternal positions for delivery, with the critical steps to care for both mother and newborn imminently after delivery. And then we progress to the future of maternal care with Camella and Stephanie Hayes and Dawn Kerslake. And in this episode, they discuss really the importance of governance and embedding midwives within pre-hospital care at both consultant level, but also having that integrated paramedic piece where you're training and mentoring paramedics into these roles. So we discussed governance systems, patient follow-up, support mechanisms, also the proclivity for PTSD and how we mitigate PTSD from some deeply traumatic maternity calls that we can attend. Okay, it's a fantastic compilation. There's some real pearls of wisdom, but also some real insights into those first phases of care and the importance of thermal care in those first few moments after birth. Okay, I do hope you enjoy. We'll catch you again on Monday for our next episode on physiology-guided resuscitation with Mark Faulkner and how we can use physiology to really guide and steward our management of cardiac arrest. Okay, we'll speak to you soon.
I mean, I would just say that thermal care for a newborn is not a nicety. It's a matter of life and death. And some of the most life-saving things that pre-hospital clinicians do for babies is to keep them warm or try to warm them up if they're cold. There was some research done by Dr. Laura Goodwin, which showed that for every degree a baby is below 36.5 degrees, the mortality risk increases by 28%. And I think that really hammers home the point that, you could have a perfect pregnancy, you could have a great birth, you could come out in tip-top condition or require, have the best newborn life support. But if they're cold, they could die anyway. And I guess if I come on to kind of the physiology behind that, just to emphasize the point, essentially what's happening is these babies have what we call brown fat, and they can metabolize it through non-shivering thermogenesis, which is basically where they metabolize this brown fat, which is basically spread across their shoulders. Obviously the more term they are, the more they have, so preterm babies would have less brown fat. But when they do non-shivering thermogenesis, it's an inbuilt mechanism in them to provide heat and to maintain heat. The problem with it is that if they have to do that for too long, it does use oxygen and glucose to metabolize that brown fat. And so the baby will become hypoxic and hypothermic, hypoglycemic and hypoxic. And obviously that can result in brain damage ultimately, or death. So I think the physiology really shows us the importance, and there's a course that has been developed. There's a few of us across the country now that are faculty with the Resus Council UK out of hospital newborn life support course, and actually the algorithm that we're using is TABC, so thermal care even before airway, to emphasise that point. So we get the baby optimised in terms of drying, wrapping on a thermal mattress before we even open the airway. And yeah, I guess the other thing to consider is that the margins for a baby being unwell are much stricter in terms of the temperature. So a normal temperature for a baby is 36.5 to 37.5, but even a baby with a temperature of 36.3 is a baby that's at risk of getting very sick and ill and dying, if measures are not taken to warm that baby up. So whereas in an adult, obviously the margins for the patient becoming sick are not as strict as a newborn. And all of what I've just said is much more significant in a preterm, as I kind of mentioned around the brown fat. They've got less brown fat, but they're more likely to be at risk of hypoxic injury anyway. They may have been born early because of infection, or they're more likely to get a congenital infection during the process of birth. And the combination of all these things for a preterm baby can be life limiting, actually. And the other thing about preterms is that they really need surfactant. We give surfactant artificially in hospitals to preterms, and that basically stops the lungs collapsing with each breath, a bit like opening a balloon multiple times. And surfactant doesn't work as well when babies are cold. So there's so many reasons to keep babies warm. And the thing is, it's not about just warming them up, it's about keeping them warm once they are warm. So in terms of what measures can be taken and should be taken, my main message would be use everything you have available to you. So in terms of the environment, don't overthink it. Shut the windows, turn off the fans, crank the heating of the property, the ambulance, and then use everything you have available to you. So dry towels. So for a term baby, they should be thoroughly dried, their head thoroughly dried, and a hat placed on their head. Hats are life-saving bits of equipment for babies. If you've only got a couple of towels, ask the parents if you can borrow some of their towels, as many towels as possible, as dry as possible if they're term, and I'll come on to preterm in a minute. If you've got a thermo mattress available to you, then definitely use it for every birth. Some trusts have blizzard blankets as well that they can wrap the baby in. Skin to skin should be used with caution pre-hospitally. I would say as a midwife, it's my bread and butter to use skin to skin, but actually in a pre-hospital setting, it's not as simple as that. We need to have a warm parent. We don't do it for transport. It's not safe for transport. And we also need to just be really aware of the airway monitoring on skin to skin, because there has been babies asphyxiated skin to skin where they've not been monitored. And I guess in terms of preterms, so I mentioned about terms and how we manage them and what we can do to keep them warm. With preterms, the recommendation is that below 32 weeks, the baby is put into a plastic bag wet, ideally at the point of birth, and then put onto a heat source. So it must only be done if there's a heat source available. You can actually just use a food grade bag. You have one end, it's the sealable end, and then you make a small hole in the other end. You gather it up like a poncho and put it over their head. And I have actually just filmed some videos demonstrating this, which are going to be widely available. So for that preterm baby, what that does is it's like the greenhouse effect, but it also helps with reducing insensible water loss from their respiratory system, and it also helps with skin integrity. So it's really, really important. And then that baby we should dab dry the little preterm baby's head, apply a hat as well. So really the message is always consider your baby's cold unless you're really clear it's not. We don't worry about hyperthermia in babies. We are really worried about hypothermia. And we should consider that all the time. And actually, the research shows that even in really hot countries, babies get cold. So unless you're literally dripping, sweating hot, that room will be too cold for a baby. Yeah, and I'm so glad that you're asking about this, because I'm actually I've just finished writing the imminent birth guideline for JL Calc with a couple of other people, and we're hoping that it's going to be signed off in July. So really, I can cover what will be in that guideline, and it's really about trying to empower pre-hospital clinicians to make that really difficult decision: do we stay or go? And there's been some significant incidents that have really played into the need to update the guideline and empower them more. And of course, this decision has always been made, at 2 a.m. when everybody's tired and it's dark and raining. And actually, they can't do cervical examinations like we would do as midwives to assess labour progress. And there's other things that we would do as midwives that would help us to acknowledge at what point she is in the birth process. So in terms of JR Calc, and the guideline, really we're looking for a contraction interval, and if it's every 1 to 2 minutes, so the end of one contraction to the beginning of another contraction, if the interval is 1 to 2 minutes, that would indicate that the birth is that she's in advanced labour. But what we would also want to see is one of the following, which is either an urge to push and or the top of the head is visible. So we would recommend that we would, and obviously I'm saying head, but it could be breech. So in these circumstances, if I cover head down, so we would recommend that the ambulance clinicians get consent from the mother, and then during a contraction have a look to see if they can see the top of the head. So if you did have contractions with an interval of 1 to 2 minutes and you had one of those things, urge to push or vertex visible, or both, during contractions, then you would correctly think this birth was imminent and you'd make a plan to stay. Obviously getting resources present, escalating to the right people to make sure you've got enough people there, setting up your kit, setting up a newborn life support area, which we would recommend always to be off the floor because of drafts, and also a firm flat surface, ideally off the floor. So getting all that ready and then offering Entonox to the woman if she would like it, and supporting the birth. Now, something that's often confused is with pre-hospital clinicians is people think that if you can see the top of the head, then that's crowning. Actually, crowning is when the largest part of the baby's head is through. It's where a crown would sit on your head. So it's actually much more, it's literally one contraction away from the baby's head being out. That's crowning. So up until that point, we would call it vertex visible or head visible. So what we want clinicians to do is make this a continuous dynamic assessment. So what we're introducing is what we call the 10-minute rule. So every 10 minutes, we want to assess whether we should still stay on scene or not. So if we are not seeing progress after 10 minutes, or we can still see the same amount of the head visible, then we want the clinicians to change the plan and to extricate and go into hospital. Obviously, this is a wider decision in terms of how close you are to the hospital and all of these kinds of things. But we really want people to be thinking, if I make a plan to stay on scene, I need to change that plan quite quickly if things are not advancing. The reason for that is because actually progress in labour is a lot more nuanced than just an urge to push, which can actually come and go. And actually some women get an urge to push at around 6 or 7 centimetres if their baby's in a mal position, if their baby's back to back, for example. And also there can be situations where vertex can be visible and then not advancing. And it could be that either the woman's got a very full bladder, or it could be that the woman has female genital mutilation, or it could be that the woman requires an episiotomy. So those are things that are under the midwifery scope of practice to catheterize at that point, or to do an episiotomy or defibrillation. And so those things are required, the woman will require to be in hospital. So that's why we are introducing this, is because there has been incidents where we've made the decision to stay, but then we're still there an hour and a half later and the baby's still not here. And the reason why this is all so important is because if I'm a midwife looking after a woman in the second stage of labour, which is when they're pushing, then I will be listening into the baby's heartbeat after every contraction or every 5 minutes, whichever one is first. And I'll be listening for a full minute, and that will give me an indication of whether there's any fetal hypoxia. So as pre-hospital clinicians, they can't do fetal monitoring. It's not within their scope of practice. So if we are with a woman who's pushing for an hour, that baby has missed out on 12 at least assessments of fetal hypoxia. So that's why actually the second stage of labour, we know that that's the time when more hypoxia happens. And so if the birth is not truly imminent, we want to change the plan and go. And we acknowledge that this will mean that some babies will be born in ambulances, because we don't have a crystal ball, and of course things can change. So we would recommend that people always have their equipment available with them whenever they're with a woman. And also acknowledging that, we're saying 10 minutes, but we understand that it's going to be a communication, it's going to be a dynamic risk assessment, it's going to be requiring communication with the woman and her family, and helping a woman who's feeling a strong urge to push out of a property is no easy task, but hopefully with really clear communication around the need to actually get the woman to definitive care, the clinicians will feel that they can change the plan if needed.
Well, that's fantastic and really thorough, actually. And it does really, really systematically help clinicians. Like you said, that reevaluation really helps clinicians to walk things through with colleagues on scene, and indeed maybe the emergency operations centre, as to whether, like you said, risk benefit analysis as to whether to go or stay. When they do decide to stay, and this seems like quite a basic question, but have you got a preference to sort of maternal positions that would indeed assist delivery of that child from a gravitational perspective, such as McRoberts, or what would you advocate is the optimal position to facilitate delivery?
Yeah, so really it's up to the woman to decide where the position that she feels comfortable in. Most women naturally, in my experience, do actually choose quite an upright position, particularly in advanced labour. So on their knees, kind of leaning up against something, is quite a naturally more comfortable, more. It feels like that's what their body often tells them to do. We wouldn't advise a woman, if a woman was completely flat on her back, for example, we wouldn't recommend that, just because of the blood flow back to the woman's heart. It could be reduced by the gravid uterus. So if she wants to lie down, being on one of her sides would be more preferable. To be honest, as a midwife, I'll often suggest things to a woman, but really leave it up to her to decide. Sometimes if the birth is not progressing, I might suggest to her, why don't you move, why don't we try a different position? Because actually just moving can often help the birth to progress. We wouldn't advise giving birth on a toilet, ideally, although obviously sometimes it does happen. That does just increase the risk of tearing, to be on like a toilet or a birthing stool, right at the end anyway. I guess McRoberts is, I'm glad you've mentioned that, because McRoberts is often really confused in the pre-hospital setting. And just to really clarify, it's a very specific situation that we would do that. So At the moment, it's currently defined as when the head comes out, and it needs to be fully born for it to be a shoulder dystocia. So if the head comes out and after 2 contractions the body is not born, then we would want to declare a shoulder dystocia, and the first manoeuvre would be McRoberts. So this is a really life-saving manoeuvre, essentially, where we need the woman actually in this situation to be completely flat on her back. So this would be so flat on her back that she can only see the ceiling above her head. So not even one pillow underneath her head. And then ideally with one person either side, her legs would get fully extended and then fully hyperflexed. So she would be completely lying flat, and then her knees would be brought back right to her, basically to her face, keeping the knees parallel. So another mistake is that often people think if you open the legs wide, actually, surely that would help. But actually, if you open the legs wide at that point, the pelvic outlet actually reduces in diameter. So we want the legs to be stretched out, extended, and then hyperflexed and kept parallel. And then somebody needs to do gentle axial traction, which is where they put their hands either side of the baby's head and only direct the baby in line with the floor, parallel to the floor, so not pulling downwards. McRoberts is 90% successful in resolving shoulder dystocia if it's done properly. That's why I've really specifically talked through how to do it properly, because if you do it properly, it is very likely to work.
Yeah, Camella, could you speak to some of we've spoken about thermal care and the importance of thermal care once the baby is born. And I think the first steps from any NLS course is sort of stimulate the baby and get them to do some of the work of breathing themselves, just to see where you are as a baseline. Just as almost just as a synopsis, could you maybe just run us through some of the critical steps immediately after birth that you would look from a clinician?
Yeah, absolutely. So we know that at birth, a third of the baby's blood volume is still in the placenta. So we want that blood to ideally get into the baby because it's carrying stem cells, it's carrying hemoglobin, it's warm, and it's like a blood transfusion that's perfectly matched to the baby. So ideally, we would leave the cord intact for as long as possible for that placenta to drain of blood. But what we would recommend at all births in the pre-hospital setting is for the first 60 seconds, the focus is, as you've said, thermoregulation, but also assessing the baby. So colour, tone, breathing, heart rate. So can't take baby home is the way to remember that. So we assess colour, tone, breathing, heart rate. So we're looking for central perfusion. So that's the mucous membranes like the lips, ensuring that they are well perfused. Tone, obviously, if a baby's floppy, we're going to be concerned. When we talk about breathing, we're talking about spontaneous adequate breathing. So that's a breathing rate of between 40 and 60 and a heart rate of over 100. And we would auscultate that with a stethoscope. So that's your first 60 seconds, basically. That's the care we need to be doing, is the assessing and the thermoregulation. And then at the point of 60 seconds, that's when we make the decision whether we need to do the newborn life support or whether we continue with care by mum. Hopefully the baby has done a big cry at this point and everyone's very happy. We apply the hat, we make sure the towel is dry and changed, and making sure that the baby's nice and warm, ensuring that the airway is open. And then in terms of mum, really it's important to be doing her observations, and we are actually soon to release a maternity decision tool for the UK, and that has got the normal parameters for a pregnant or recently birthed patient. And so we would say that during labour and following birth, we should use that tool or use those parameters, because we know that NEWS 2 is not validated in pregnancy or postnatally up to 4 weeks. And so that's why we're introducing this tool. So we want to take the vital signs of the mother and then monitor for bleeding, really, and monitor for the placenta to come. There's a few things that people can do to help the placenta to come. So in the new guideline, we are going to say that if the placenta is still in situ at 20 minutes, then we want to pre-alert and go into the maternity unit. That's because of the PPH, the postpartum hemorrhage risk is increasing when the placenta is in situ after that, and because we don't do active management of the third stage in the pre-hospital setting, or not as ambulance clinicians anyway. So to aid the placenta to come out, we can help the mum to maintain a kind of an upright position, or get into an upright position where gravity can help the placenta to come. We can also, if she would like to breastfeed or have skin to skin, that will help the oxytocin which will help the placenta to come. But obviously ambulance clinicians are not expected to provide active breastfeeding support. And then also, if she wants to pass urine, or she can pass urine, then having an empty bladder will mean that the placenta is more likely to come. So they're kind of the immediate sort of general care that I would expect to be given to mum and baby after birth.
Steph, could I get you to speak to, so Dawn mentioned, and very quite rightly so, just how emotive these cases can be and how career-ending they can be, if not handled appropriately. But could you speak to sort of follow-up, and indeed sort of patient follow-up from a maternal perspective, and indeed a pediatric and/or neonatal perspective for clinicians?
Yeah, absolutely. And as you say, these cases are really, really emotive, and actually the need for that kind of really structured and formalized debrief is absolutely paramount. But as we know, in reality, that's not kind of standardized. And I think it's a real gap that we have, not only in the pre-hospital setting, I would kind of say, I think even in maternity services, healthcare services, kind of as a collective, actually, we are not very good at doing that kind of formalized debrief, that cold debrief, that kind of hot debrief, and how we were supporting staff when they are involved in a really emotive case. So I think there's lots of work to be done in that space, I would say. I would kind of note that actually we've got quite a good model in MWAS, which is the TRIM model. I don't know if you've heard of that, Owen. It's the Trauma Risk Incident Management System. So one of our consultant paramedics for education actually was part of the development of the TRIM, which really does support. I think there's still kind of gaps with anything, because I think you have to kind of unpick that. Actively seeking out the TRIM, or being okay to kind of speak up and ask if it's your direct line management around getting that kind of level of support. But I do know as well that we have kind of, national support services in the pre-hospital ambulance service that staff can kind of tap into should they wish for some kind of focus level of counselling. But I would say, yes, there's a gap, I would say, something we need to focus on. I don't know if kind of Dawn, you got anything to add on that kind of emotive element of that kind of pre-hospital maternity care?
No, only that it's really important to be available, and I try to be available whenever I can to do that immediate debrief if the crew need it, and then try and speak to their line managers and get them stood down, because we're not always that compassionate. I think we get so, as in my colleagues within the ambulance service, that they've got to get enough ambulances out on the road, and therefore standing somebody down is quite a big deal. But we've got to care for people, because we know that if we care for people, they perform better and they don't go off sick for weeks on end. So we've got to get better at it. And it's about being available, and it's about being approachable. It's all those things that make you a good leader, isn't it? In terms of staff being able to pick up the phone to you or send you an email and say, actually, I found this really difficult and I'm really struggling. That would be my take on it.
Yeah, I think one element to this is that I think is really important is actually having pre-hospital midwives, or midwives that work in the ambulance service, because they can actually provide that kind of subject matter debriefing about a really specific maternity incident, which I think crews really appreciate. When they've been through kind of this very difficult situation, even if there's a good outcome, it feels really difficult because they're having to do such a specialist thing. And having that opportunity to reach out to a midwife and ask them, so when that happened, why was that happening? Or what could I have done to help that woman understand the situation better? Or and kind of drawing on those subject matter experts, I would say, in inverted comma, commas to say to help them to understand the situation more. So something that I've done in London and I am doing at the moment in East Midlands is having maternity newborn care leads who are paramedics. They do it actually on top of their day jobs, and across different grades, across different areas. So in London, we've got there's about 19 clinical team managers, one for each group station. And they kind of have their ear to the ground in terms of any crew members that may be feeling distressed following an incident. They help us review incidents, and we review pretty much all pre-hospital births and obstetric emergencies through that way. And then they really look at the welfare element as well. And they'll support the crews there and then, and we give them extra training. But also then they can link us in where appropriate. So if the crews do have further questions, because actually often in my experience, them just not understanding what has happened or wanting a bit more of the pathophysiology behind what has happened actually helps them to process those really difficult events more, and empowers them that if they went to a similar situation, they would know that element, that extra bit, and be able to contribute to that situation. So I think by having midwives available, I think trusts are able to support staff better. But I think, as already has been said, I think we do have much further to go with that. And as a national leads group, these are the kinds of things that we consider to say, how can we support crews better nationally following these really difficult incidents.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.